Good afternoon. How was your long case? How do you feel about it?
Good afternoon, sir. Sir, my long case went well, sir. I feel that it went well, sir.
Then we'll start with your Viva. Is that okay with you?
Please, sir.
So let me ask you some more questions regarding depression. Are you aware of any recent national surveys that looked into prevalence of depression?
Yes, sir. The National Mental Health Survey has looked
Okay.
into the prevalence of depression.
Tell me its salient findings.
So the National Mental Health Survey has reported that the lifetime prevalence of depressive disorder is around 5.2%, whereas a cross-sectional or a current prevalence was around 2.7%. It is highest according to NMHS in the 40 to 59 age group, more in females and more in people living in cities with population of more than 1 million. It also said that there is around 80% treatment gap that exists in depression, sir. These are some things that I remember about NMHS which are specific to depression.
So in depression, we normally talk about major depression. Do you know what minor depression is?
Yes, sir. So minor depression is a construct in which depression of lesser severity, like dysthymia, and earlier we were using terms like anxious depression, neurotic depression, characterological depression. All of these are included under the rubric of minor depressive disorder, sir.
We have talked about minor depression, treatment-resistant depression. What about difficult to treat depression?
Yes, sir. So whereas treatment-resistant depression is an unidimensional construct, wherein it focuses purely on an symptom improvement as rated in a rating scale and doesn't look into any other thing. We talk about in difficult to treat depression is a more holistic kind of a term in which it is important also for clinical practice. It takes into account what is the quality of life of the patient, what is the functioning of the patient as compared to before. And the key difference is that while in treatment resistant depression, we focus on remission only. In difficult to treat depression, we actually kind of look at, in addition to the response, whether the patient has returned to an optimal level of functioning based on his pre-morbid functioning. So this is what I remember about difficult to treat depressions.
Name some biomarkers in depression.
So biomarkers in depression, traditionally, the earliest one that was studied were things like hypercortisolemia, and therefore the dexamethasone suppression test, which was used earlier in depression. Then came the polysomnography and the sleep studies, which found that there is a decreased REM latency, there is an increased REM density and poor sleep continuity with fragmentation. Then came the inflammatory hypothesis and the biomarkers related to inflammation, such as the C-reactive protein, and also the neuroimaging biomarkers, which showed that there is an increased resting state glucose activity in certain parts of the brain, like the right anterior insular region. And there's decreased hypoactivity, there is decreased activity in regions such as the dorsolateral prefrontal cortex. These are some biomarkers I remember in depression, sir.
Anything out of this that can help you predicting clinical outcomes or your choice of antidepressant or both?
Sir, not all, certainly not all, but as far as I remember, the C-reactive protein has been used with translational implications. So it is relatively inexpensive, and it has a predictive utility to decide what choice of antidepressants we can use in our patients. There was the study trial data that was used by the genome-based therapeutic drugs for depression group, and they looked into combining medications to enhance depression outcomes study, that is the COMET study, in which they actually used this data from the study trial and found out an interesting finding that in people in whom there was a C-reactive protein less than 1 seemed to respond better to SSRIs, and people in whom the C-reactive protein is more than 1 seem to respond more better to TCAs and SNRIs. So this is one biomarker which has been used with translational implications.
What is allopregnanolone?
Allopregnanolone. Sir, it is a first drug that has been approved by FDA specifically to treat postpartum depression. As far as I remember, it's a steroid. It is a metabolite of progesterone, and it is perhaps the only medication that I know in psychiatry which is given as an infusion continuously for about 60 hours, sir.
Any repurposed drug that is used in depression?
Repurposed medications specific to depression. So repurposed drugs are medicines that are primarily used for some other indication in pharmacology, but have been repurposed for a use in psychiatry. And one such drug that has been used and which has a lot of traction in recently is ketamine, sir.
Okay, but how is it used in depression?
Yes, sir. Sir, as far as I know, that there is two varieties of ketamine that are generally used. One is racemic ketamine, that is a mixture of both S enantiomer and the R enantiomer, that is used most commonly in the intravenous route, given 0.5 to 0.75 mg per kg body weight over 40 minutes, 3 to 6 sessions, which is commonly used. There is the other enantiomer, that is the only using the S enantiomer of ketamine, which is used as a nasal spray, which has recently been FDA approved also. That is the S ketamine. So I know about these two formulations being used in depression.
Fine. Enough of pharmacology. Tell me something about the social origin of depression. Is there a study that you know that looked into this?
Yes, sir. The social origins of depression, based on the landmark study by Brown and Harris, which was published, I think, around 1978, which looked into factors that make a person more vulnerable for depression. They said that if they have a poor social support, if they have more children less than 14 years of age, if they are unemployed, if they have early maternal separation or a loss, ongoing serious social stressors, they said that they are more likely to provoke depression. Now, at a time wherein there was a buzz about biological psychiatry, this study showed that there is social origins that also mediate psychiatry illnesses, sir. That's what I remember.
Anyone you know who classified suicide and has given types of suicide socially?
Yes, sir. Durkheim, around the 1900s, gave 4 types of suicide, sir, wherein he described suicide as an epiphenomenon to changes in the society. And he said that the types of suicide could be an altruistic suicide, egoistic suicide, anomic suicide, or a fatalistic suicide.
Can you name some psychological theories of depression? Just briefly about them.
Yes, sir. Sir, earlier theories were more psychodynamic theories that looked into the infant and the mother relationship and attachment injuries that happen early, and the infant internalizing or introjecting, using introjection as a defense to deal with perceived sense of loss. And also it looked into some coexistence of anger, love, and hatred, which then leads to anger turned inwards and leading to depression. Then came the psychological theories, which looked into the behavioral models, wherein Seligman built upon Ariadne's theory and gave the learned helplessness model. And then came the attachment theories, in which Bowlby said that if there are early attachment injuries in later life, that can lead to interpersonal difficulties and depression. But largely, what theories that we use right now is the cognitive theories. And most famous of that is the Beck's cognitive model, in which he talked about the negative cognitive triad of the I being defective or inadequate, all experiences result in defeat or failures, on the future is hopeless. So these are all false, and they come under the rubric of the negative cognitive triad. These are some psychological theories I know about depression, sir.
Do you know the concept of involutional melancholia or involutional depression?
Yes, sir. Involutional depression is a traditional name given for a psychiatric disorder that affects the elderly, that is in late life, and it is usually accompanied by paranoia. It deals with depression that comes at a late life, and it has more melancholic features associated with it, and probably has an endogenous component as a predominant component.
What is California rocket fuel?
Sir, in STAR-D, in the last phase, they use a combination of venlafaxine and miltazepine, and this combination is usually called as California rocket fuel. In terms of efficacy, they say that this combination of these two agents results in a potent serotonergic and a noradrenergic response, and therefore it is used in resistant depression as a combination.
Okay. Talking about resistant depression, you mentioned about MAO inhibitors. Why should we not, or what should we be careful about MAO inhibitors in resistant depression?
Sir, in case we use MAO inhibitors with other serotonergic agents like SSRIs, or even agents like tramadol, or we use it with concurrently with tyramine-rich foods like cheese, milk, then it can lead to, theoretically, it can lead to serotonin syndrome, which we need to be aware of, sir.
How will you know it's serotonin syndrome? Any criteria that you know to diagnose it?
Sir, there is the Hunter's criteria and the Sternbach criteria. Both the criteria actually talk about a triad, sir. The first component of the triad is an altered mental status, wherein the person might have anxiety, agitation, restlessness, even disorientation. The second component of the triad is neuromuscular abnormalities, wherein there is tremors, there is clonus. The clonus can either be spontaneous clonus or ocular clonus, and hyperreflexia with even Babinski positivity bilaterally. The third component of the triad is autonomic hyperreactivity, wherein the person might have hypertension, tachycardia, tachypnea, mydriasis, flushed skin, and shivering.
How will you treat this in emergency?
Sir, in emergency, we can treat serotonin syndrome by removing the offending agent, stabilizing the airway breathing and the circulation. And in case this doesn't help, then we can go for pharmacological strategies such as using ciproheptadine in the dose between 8 to 32 mg per day.
Do you know any recent neuromodulation that is used in depression?
Yes, sir. So with respect to neuromodulation strategy, although ECT remains the gold standard neuromodulation strategy for depression, and no other neuromodulatory mechanism or treatment can actually come close to it, but some two neuromodulatory techniques which come close to its efficacy in non-psychotic depression is the transcranial direct current stimulation and the repetitive transcranial magnetic stimulation. In both of these treatment modalities, it usually targets the dorsolateral prefrontal cortex. There are other neuromodulatory techniques such as vagal nerve stimulation and deep brain stimulation, whereas the vagal nerve stimulation and RTMS have been approved for use in depression by the FDA. DBS, that is deep brain stimulation, is still for experimental use only. So this is what I knew about the other neuromodulatory techniques in depression.
Good. I think you have done well, and this will be all from my side.